Let's learn about the thyroid gland. The thyroid gland is a butterfly-shaped endocrine organ. As you know, it's located in the midline below the larynx and in front of trachea at the level of C5 to T1. And it consists of two lobes, left lobe and right lobe, connected to each other by a connective tissue called isthmus. This is the thyroid gland. This is the outline of thyroid gland. This is the larynx. This is the it is located below the larynx and in front of trachea. The artery supplied by this is the superior thyroid artery, and this is the inferior thyroid artery. This two artery supplies the thyroid gland. The superior thyroid artery is a branch of external carotid artery, and inferior thyroid artery is a branch of thyrocervical trunk. And this is the arch of aorta. Suppose this is our arch of aorta. Many three arteries are originated from the arch of aorta. This is the first one. This is the second one. And this is the third. This is the left subclavian artery. This is the left common carotid artery. And this is the brachiocephalic trunk. Brachiocephalic trunk again give rise to two branches. This is the right common carotid artery, and this one is the right subclavian artery. Suppose this is our thyroid gland, and this is our the left common carotid artery. This is the right common carotid artery. The left and right common carotid artery give rise to a branch called external carotid artery. From the external carotid artery, from both sides, left and right side, artery enter the thyroid gland superiorly and supply the thyroid gland. This is the superior thyroid artery. Left subclavian artery give rise to a branch, and the right subclavian artery give rise to a branch. This branch is called thyrocervical trunk. A branch originated from the thyrocervical trunk enter the thyroid gland from posteriorly from both left and right side. Both left and right thyrocervical trunk give rise to a branch that enter the thyroid gland from posterior side. This is called inferior thyroid artery. So superior thyroid artery enters the thyroid gland from superiorly and supply the thyroid gland, and inferior thyroid artery, which is the branch of thyrocervical trunk, enter the thyroid gland from posteriorly and supply the thyroid gland. Now the nerve supply is by parasympathetic is supplied by the superior laryngeal nerve and recurrent laryngeal nerves, which is the branch of vagus nerve. This is the parasympathetic supply. Sympathetic supply is by the superior, middle, and inferior cervical ganglion of sympathetic trunk. Histopathologically, thyroid gland consists of thyroid follicles. Suppose this is the thyroid gland. And thyroid gland have small structure inside the thyroid gland. This we called the thyroid follicles. Thyroid follicles are structural and functional unit of thyroid gland. It has a single layer of follicular cells surrounding a central lumen filled with colloid. These epithelial cell is called the follicular epithelial cell, and this is the colloid. These are round structures called the thyroid follicle cell. These are the small epithelial cells that surrounds a central lumen filled with colloid. In between the thyroid follicles, a structure is present called the parafollicular cells. The parafollicular cell is present here. The parafollicular cells located in the interfollicular connective tissue. These parafollicular cells helps in secretion of calcitonin. It play a role in calcium homeostasis. Suppose these are our follicular cells. In between these interfollicular connective tissue, here is a location of the parafollicular cells, helps in formation of calcitonin. And here the location of blood vessels. Now let's discuss about the synthesis of thyroid hormone. The synthesis of thyroid hormones occur in the thyroid follicles. And iodine is the crucial for the synthesis of thyroid hormone. Iodine is essential for the thyroid hormone synthesis. Lack of iodine suppress the thyroid hormone synthesis and release. This is the blood vessel, and this is the thyroid follicle cell. The thyroid follicle cells contain the outer layer of follicular epithelial cells, uh, which surround the colloid. The inner portion is the colloid that surround the colloid. These follicular epithelial cells have the outer layer, which we called basolateral membrane, and the inner layer, which we call the apical membrane. The first step in the synthesis of thyroid hormone is iodide uptake or iodide trapping. The iodide from the bloodstream is actively transported into the thyroid follicles via the sodium iodide symporter. Sodium iodide symporter. So, with the iodide, sodium also acts into the thyroid follicles. Iodide is then transported across the apical membrane of the follicular cells into the colloid. Here, enter into the colloid by a transporter. Here is the presence of a transporter is called pendrin. Then the iodide is oxidized with the help of the enzyme TP or thyroid peroxidase. While the transportation of iodine, at the same time there is the formation of thyroglobulin from the endoplasmic reticulum of the epithelial follicular cells. Suppose this is the endoplasmic reticulum, and which synthesize a large glycoprotein called the thyroglobulin. This endoplasmic reticulum synthesize a large glycoprotein called the thyroglobulin at the follicular epithelial cells. Now, this thyroglobulin is then transported to the colloid, and in the colloid, the iodine attached to the tyrosine residue present on the thyroglobulin. This process is catalyzed by TPO, and this process is called the organification. Suppose this is the thyroglobulin, and these are the tyrosine. This is the thyroglobulin, and this is the tyrosine. Tyrosine residue and iodide attached to these tyrosine, and after the attachment of iodine to the tyrosine residue, there occurs the coupling reaction. Suppose this is the tyrosine on which the iodine attach. On some tyrosine residue, the single iodine attach, and on some tyrosine residue, there is attachment of two iodine molecules. So this is the monoiodotyrosine. This is the diiodotyrosine. Then there is coupling occur, that is one molecule of MID combined with one molecule of DIT. One molecule of monoiodotyrosine combined with the double iodotyrosine, and that's how the formation of triiodotyrosine, and which we will call T3. And similarly, two iodotyrosine, two molecule of DIT combined to form tetraiodotyrosine, which we call T4. So we can say that after coupling there is a formation of T3 and T4. There is MIT and DIT as well within the thyroglobulin molecules. So when the thyroid hormone is emitted, the thyroglobulin containing T3 and T4 is endocytosis. Then the endocytosed vesicles fused with the lysosome. Then this endocytosed fused with lysosomal enzyme. These are the lysosomal enzyme which contain proteolytic enzyme. This enzyme digest the thyroglobulin, result in release of T3 and T4 into the circulation. T4 is predominantly secreted hormone. It is converted into the T3 in the peripheral tissue by deiodinase enzymes. And this is the synthesis of thyroid hormone. And now the crucial clinical link with this synthesis. There are few drugs that block the sodium iodide symporter. Sodium iodide symporter blocker. And these are perchlorate. Second one is thiocyanate. And third one is nitrate. Not mainly used nowadays. Sometimes they can be used in case of amiodarone toxicity that we will discuss later. And then we have another clinical link, that is the pendrin syndrome. There is number one, sensory neural hearing loss, and second is goiter. The pendrin syndrome is because of mutation in SLC26A4G, and this gene encode for pendrin protein, and pendrin protein is again responsible for transportation of chloride, bicarbonate, and iodide across the cell membrane in the inner ear as well in thyroid gland. So defective transportation result into the pendrin syndrome. Now suppose a child is exposed to radioactive iodine, then what will happen at the level of thyroid gland? This radioactive iodine use the same transporter, that is sodium iodine symporter, and enter the gland and result in destruction of thyroid gland and decrease the synthesis and excretion of thyroid hormone. And to prevent this, we used immediately potassium iodide, also called the Lugol solution. What it will do is the use of same sodium iodine symporter and flood the thyroid gland with stable iodine and block the uptake of radioactive iodine and temporarily inhibit the release of thyroid hormone from the thyroid gland. The Lugol solution was used as the primary treatment for the hyperthyroidism, but not used nowadays for the treatment of hyperthyroidism as a primary treatment because it temporarily blocks the release of thyroid hormone. Nowadays, this Lugol solution is used 7 to 10 days before the thyroidectomy, that is the removal of thyroid gland, especially in case of grave disease. Then we have compounds or drugs that inhibit the deiodinase. The drugs that inhibit the deiodinase are, the first drug is amiodarone, second one is propylthiouracil, third one is propranolol, and fourth one is the steroid. These are the deiodinase inhibitors. So these drugs also used in case of hyperthyroidism, also in case of euthyroid sick syndrome. Now it's the right time to discuss the two important concepts. The first one is, what is Wollf-chaikoff effect? And second one, what is Jod-Basedow phenomenon? What is Wollf-chaikoff effect and what is Jod-Basedow phenomenon? What is Wollf-chaikoff effect? The Wollf-chaikoff effect is the autoregulatory mechanism of thyroid gland when the iodine level in the blood become elevated in normal person with normal thyroid gland. Suppose when we take a higher amount of iodine, for example, either we take a medicine that contain iodine, for example, amiodarone, or after the iodine contrast injection that we use to enhance the visibility of blood vessels during X-ray or CT scan. So whatever the case might be, when the level of iodine increase in the body, then there is acute transient inhibition of thyroid hormone synthesis because of excess of iodine. This is the protective phenomenon to prevent the thyrotoxicosis by suppression of iodine organification primarily through the inhibition of thyroid peroxidase. Because of inhibition of thyroid peroxidase, that's how we prevent the organification. This effect is self-limiting, typically lasting a few days, after which the thyroid escape from this inhibition. What happened here? This escape is largely mediated by downregulation of sodium iodine symporter. That is sodium iodine symporter downregulate, which decrease the intracellular iodine concentration and allow the hormone synthesis to resume. The failure of this mechanism can lead to the iodine induced hypothyroidism. A particularly susceptible population with pre-existing thyroid condition, fetuses, neonate, or those exposed to high iodine pharmaceutical agents like amiodarone or radiograph contrast media. And this is the Wollf-chaikoff effect. The excess of iodine inhibit the thyroid hormone synthesis, and this is the self-limiting condition. Now, what is Jod-Basedow phenomenon? Suppose we supplementing iodine in a iodine deficient area, and because of already deficiency of iodine in that area, there may be people with pre-existing thyroid condition, for example, thyroid goiter, because of deficiency of iodine. Okay, in this case, when the people with pre-existing thyroid condition were exposed to higher iodine level, and there is development of hyperthyroidism following iodine intake, characteristically by sustained increase in thyroid hormone synthesis and eventually thyrotoxicosis. Suppose this is the thyroid gland. The mechanism is either the overactivation of entire thyroid gland, and more commonly the autonomous functioning of a nodule. There is presence of nodules because of pre-existing thyroid condition, and the autonomic hyperfunctioning of nodules within the gland upon iodine repletion. This is often described as the failure of protective Wollf-chaikoff effect, and Jod-Basedow phenomena doesn't go away by itself. We need a treatment with the antithyroid drug for few days. So, to summarize, what happened in the case of Wollf-chaikoff and what happened in the case of Jod phenomenon. Suppose if there is excess of iodine in the body, so what happened in Wollf effect? That is iodine induced temporary inhibition of thyroid hormone. And what happened in Jod? There is iodine induced hyperthyroidism. And the Wollf effect is physiological and protective mechanism, where Jod is pathological effect in pre-existing thyroid condition. Wollf effect occur in normal individual, whereas Jod-Basedow occur in pre-existing thyroid condition. For example, in goiter, and the Wollf effect is usually self-limiting because of development of thyroid escape, and there is Jod effect need antithyroid drug, may also need beta blocker, or sometimes there is a need of surgery. We can remember this by W is for Wollf and W is for withhold the synthesis of thyroid hormone, and J for Jod and J for jumpstart the synthesis of thyroid hormone. This is the summary of Wollf and Jod effect, and this concluded first lecture.